Can everyone hear me? Yeah. Hi, I'm Dr. Lawrence Ng. I'll be kicking off this weekend's Family Physician Skills course. This skills course is about self-care. Specifically, it's about physician self-care. And it's related to physician burnout. So it is something that I felt that was acutely needed because when I was a medical legal advisor, I was taking phone calls from doctors under stress, medical legal, medical counsel, and all that. And some have actually expressed that they are thinking of quitting practice and leaving clinical work. And then when we go on, we find that actually a lot of doctors are under a lot of stress. So without further ado, I have half an hour. Just like to read to you a friend of mine on Facebook. It's a medical student actually. And she was on a clinical posting doing CPR. Then she encountered one death, not uncommon. Encountered another death, not uncommon. And then, just to cut very short, she says that, but I whispered in my heart, it is okay to cry, and I hope you will be fine to be strong. A lot of us go through this process since we were in medical school, and it seems like a very normal process for all of us, but actually it's not a normal process for a normal human being to see 2 deaths in one day, and sometimes I think we see even more in one day. So the process of socializing to become a doctor started very, very long ago for all of us. Learning points. This is a course for a family physician, but of course, burnout applies to all types of physicians, not just us family doctors. And family practice involves direct contact with patients every day. It can be rewarding, but it can also lead to burnout. And ideas about burnout has evolved over time, and concepts and terms have now been more refined. And today I'll be presenting to you some of the latest ideas. Earlier publications were more descriptive, but later ones have begun to look into interventions and how to combat burnout. And we'll be looking into evidence-based trials that have been done. And more increasingly, we're using validated scales, such as the Maslach scale. And this paper is, actually I wrote this paper for my fellowship thesis, and it has actually been published in the journal. So it took me about 10 weeks to do this, with the help of Professor Goh, Li Gan. It is found that up to 45% of physicians have reported at least one symptom of burnout. And in one European study involving 1,400 family physicians, about 43% had at least one dimension of burnout. And 12% suffer from burnout in all 3 dimensions. Later on, we'll find out what are these dimensions. And from the perspective of patient safety, it is important to note that physicians who are burnout tend to commit more medical errors, and doctors with burnout are more likely to report suboptimal care and intention to leave clinical practice. And burnout can be seen as a missing link in the quality care and a neglected quality indicator in medicine. So the objective here is to define this very commonly encountered syndrome, what are the causes, and what are the evidence-based interventions. Okay, if you want to go to sleep after this slide, please go ahead and sleep, because this is the most important takeaway message for you and for me. Burnout has been studied by a majority psychologists, not so much doctors. There's only one doctor called Friedenberg who did a study too. And most of the work has been taken from Christina Maslach. And she wrote this in 2001, that burnout has got 3 dimensions. The first one is emotional exhaustion or simply exhaustion. The second one is depersonalization or cynicism. The third one is lack of accomplishment or inefficacy. Exhaustion component actually represents the most basic individual stress dimension, and it refers to feelings of being overextended, depleted of emotional and physical resources. In a sense, there's no more fuel left for fire. Depersonalization or cynicism is when it represents the interpersonal context dimension of burnout and refers to the negative, careless, excessively detached response to various aspects of the job. Lack of accomplishment or a sense of inefficacy is a component of reduced efficacy and accomplishment, representing the self-evaluation dimension of burnout, and refers to the dimension of incompetence, a lack of achievement or productivity at work. One doctor who's actually 1 year older than me said that she actually feels like a fake. So I said, what do you say you feel like a fake? She feels like she's not a doctor, she's just doing the role playing. So it is interesting, after 30 over years of practice, she still feels that way. So causes of burnout. Here we like to explore several factors which can be classed into 3 groups: predisposing factors, difficult encounters, and work-family conflicts. In predisposing factors, one of the first things to look at is professional socialization. It is a process in which a person becomes a doctor. A medical student learns to become a doctor. And this has a role to play in planting the seeds for future burnout. If you remember, there's always an emphasis on perfection, denial of personal vulnerability, and delayed gratification. Everything is postponed. What you want to do in your life is always postponed until this exam, that exam, final exam. Before you know it, the MRCP exam. Then after that, even for me, the fellowship exam is coming up next year. So everything is postponed. And there's an emphasis on perfection, and and the traits that made a medical student, and a doctor, a good doctor, are traits such as compulsiveness, guilt, self-denial. And these, although they may lead to success during the educational years, but unfortunately leads in later career to increased sense of inadequacy, lack of fulfillment, or a sense of accomplishment. In a professional culture such as ours, which stigmatizes weakness and frowns upon self-care, this can lead to burnout. We can't seem to keep still and do nothing. Going on holiday, after a while, on the 3rd day, I get withdrawal symptoms. I want to make spot diagnosis at lunchtime and dinner time. Predisposing factors. Another one that has been studied is intolerance to uncertainty, particularly so for junior doctors, such as in a study group involving Australian GP residents. There's a lack of tolerance or coping with uncertainty, especially in family medicine where the cases are unfiltered, the cases are undifferentiated. A headache can walk in, a backache can walk in, and you don't really know what you're dealing with. So as they transition their careers from medical school, residents face being held accountable for their medical decisions for the first time in their life. And this has been shown that the observed resilience was linked to high compassion satisfaction, higher tolerance of both general and clinical uncertainty, and those with higher resilience will have lower burnout. Difficult patient encounters. We all like to brand or label certain patients as difficult patients, but it's not politically correct to say this. So we have called this difficult patient encounters or difficult encounters. Difficult encounters are said to be difficult when they are requests for diagnostic tests, which is not according to the current guidelines, greater chronic disease burden, chronic pain, serious but undiagnosed illnesses, significant or suspected depression, and suspected substance abuse, such as cough syrup cases, common in Singapore and Hong Kong and Malaysia. Difficult patient encounters or consultation can form up to 15% of patient volume. And these are all international data, not just local data. Now, difficult patient encounters can lead to frustration and despair. It can trigger anger, frustration, leading to emotional exhaustion and burnout. It can also frustrate the patient, leading to unmet expectations and repeat visits to get what they want. And it has been found that up to a third of patient requests are not fulfilled. Now, this results in conflicts in doctor-patient relationship. The physician will view the patient as being demanding and controlling, while the patient may view the physician as uncaring, unattentive to their needs, and thus causing tension and conflict in the doctor-patient relationship. In fact, you can find that even for those of us GPs who practice aesthetic medicine, it is the same. The patient can ask for something to be done to the face, and we feel that that's not required. Gatekeeper role. We family physicians have always been given the gatekeeper role. It is not a good job to have, actually, and I'll tell you why. Now, time is a scarce resource in family practice, and difficult cases require time and effort to manage well. And we are given this role in deciding whether to make a special referral or to order certain tests. And when the test that is being requested is not according to guidelines, it puts us in an uncomfortable dilemma. Some of us may even feel that our authority is being challenged, and thereby you set up the tension in the consultation. So saying no will mean having to take time and effort to explain why the test is not needed, as well as the worry of misdiagnosis and the consequence of medical malpractice suit. Patients who request diagnostic tests may have some personality traits or communication styles which add to the difficulty of a visit. I find it's particularly difficult when the patient speaks another language other than the ones that I speak. And in Singapore, there are 4 official languages, and there are a lot of immigrants here, so it is a very difficult time trying to explain in another language why you don't want to do a certain test. Sometimes it is both parties bringing something to the table that causes this tension. So it's a physician-patient diet, And the more tension there is, the more difficult it is to untangle yourself from this. Also, we have high personal expectation, and in the consultation, there may be a lack of reciprocity. What do I mean by that? Physicians with burnout have high expectations of themselves and tend to rate their performance as suboptimal, and they also underestimate the patient's positive attitude towards them. That means when the patient is being positive towards you and give you a praise or something, you don't take note of it. Yet you may be very overly sensitive to the patient's expectations, so the patient may want you to do something that you're not able to do, something that only maybe a specialist in a tertiary hospital can do. And then you tend to rate the encounters and the patient and the relationship with these patients as less than satisfying, and so you tend to have a greater proportion of what you call difficult patients. Empathy and boundary conflict. This is particularly more acute in women, where you tend to want to empathize with the patient, but at the same time you need to set a boundary between your patients and you. So it's always a difficult balancing act. And some people are able to do it, some people can't do it. Those who can't do it either get overly involved or overly distant, and both are not good. So how to balance the two, And a lot of us do that distancing to avoid experiencing what we call secondary traumatic stress. And secondary traumatic stress actually leads to what is called compassion fatigue, which is part of burnout, but not burnout per se. Compassion fatigue is where a lot of negative stories start coming in, especially you got stories of spousal abuse and so on and so forth, And after hearing your fourth or fifth case in the morning, you get burnout. You get tired. There's no more compassion left. So compassion fatigue. Work-family conflict. This one all of us are quite familiar, so I don't have to say too much. It's actually quite self-evident. The 2 roles that we play, one at work and one at home, sometimes become mutually incompatible. And this is actually explained by the scarcity hypothesis, which is based on the assumption that resources of time, energy, and attention are limited. So when you give the attention more to one side than the other side, then it causes conflict. And in line with social expectations, physicians and families tend to concur in putting the interests of the patients above that of their own, and then that makes us, as physicians, more liable to spending inordinate amount of time at work to the detriment of time with the family. And the family actually will say, he's taking care of a patient, he's doing a good work, she's doing a good work, my daughter is in the clinic, and then you spend more and more time at work and less time at the office, and everybody's agreed to it. So exhaustion sets in when these resources are depleted, and then it leads to conflict. Especially difficult for women, because women are expected to carry both roles. So here I'm going to just run through quickly some of the evidence-based interventions that has been done. In the past 25 years, there's actually been a lot of work done, and the work has actually now been expanded internationally, and there are now new conceptual models. And in fact, Maslach herself is beginning to talk not just about the negative 3-dimension aspects, but also about engagement, but that'll be a talk for another day. Interventions basically falls into 2 levels. One is individual, one is organizational. And I did a PubMed search, out of which I chose 4 randomized controlled trials. And I'll go through quickly about the author, the year, the study design. So the first one is by Linzer, done last year. It's called a Healthy Workplace Study. It involves improvement in communications, particularly among clinicians and staff, changes in workflow, targeted quality improvement projects that addressed significant clinician out concerns. I won't go through the details. I'll just go through quickly. The second one was by Ed Goose, also done last year. It's a RCT. Total number of participants was 57. This one is based more on self-awareness, mindfulness, breathing technique for dealing with difficult encounters called the Breathe Out Mnemonic. And in fact, it has been shown to be effective. And West, this is actually quite a significant paper. And this study incorporates elements of mindfulness again, reflection, self-experience, small group learning for 9 months. And actually it's protected time. That means the staff is given time to participate in this, this kind of work. Asuro has also another RCT done 2014. It is actually a mindfulness-based reduction program and consisted of presentations of clinically relevant topics, mindfulness-based coping strategies, yoga, and group discussions. Won't go into detail on all this. So there are also other intervention strategies that has been used, and it has been suggested that there is a need for gender-tailored interventional strategies since men and women react to stress differently. For men, they tend to depersonalize first, and the focus could be on coping skills in order to prevent avoidance behavior and withdrawal. For women, the tendency is to become exhausted, so the focus could be on boundary setting and specific factors related to fatigue. This one I'd like to mention because all of us are quite guilty of this. One danger in burnout is a doctor's delay in seeking medical care due to the reluctance to play the sick role. So it is a paradox that we find barriers in seeking healthcare when we are sick. It is as if while being providers of healthcare, we are a disadvantaged and at-risk group. A Malaysian study has confirmed that physicians tend to delay seeking treatment for chronic and serious illnesses. And some of the factors are denial, minimization of symptoms, self-diagnosis, self-treatment, seeing the call for help as a sign of weakness, worry about loss of confidentiality and privacy, impact on fitness to practice. In becoming a patient, the physician has to undergo the following processes. There's a change in role in healthcare setting, there's loss of control, you're taking up the lower position in the hierarchical relationship with your doctor, a sense of vulnerability. Another area that can be improved, and actually in the College of Family Physicians we talked about it, is that of collegial support. So as people who care for patients, we can also take better care of each other as fellow professionals. So in the UK, one example would be the Physician Psychiatrist Support Service, which is a free telephone advice and support for the members. And it is a useful guide entitled How to Take Care of Yourself. In it, there is a list of questions which can be used for self-screening and for reflection. So questions regarding things like monitoring your own health, stress levels, sleep pattern, healthy living, which includes regular meals, exercise, monitoring your own coping strategies to stress, including the use of alcohol, substance abuse, network of support and interests outside of work, making changes to your work-life balance, and so on. So burnout actually as a research subject is progressing over the past years, and there's a greater and greater evidence base to choose from. The most commonly used framework is still that of Christina Maslach's, and the most widely applied scale is still the Maslach Burnout Inventory, which is called the MBI. Factors causing burnout can be divided into organizational and individual. And in this paper, we highlighted and discussed the roles of 3 groups of factors, which is the predisposing factors, difficult encounters, and work-family conflicts. So there's been a lot of work, and Mark Linzer's work actually has been incorporated into the American Association's Step Forward program, a 7-step program disseminated to all the members with the aim of reducing and preventing burnout at the workplace. So nature of medical practice is stressful. I don't think we can ever take away the stress completely, but hopefully with greater research and better understanding, the next generation of doctors may not need to face the scourge of burnout as severely as the previous generation did. So what are the learning points? I think the few things to learn is physician burnout is a real problem, but is seldom discussed, therefore poorly understood by us. Burnout has got many factors, processes, and characteristics which can be defined and studied. It occurs at all stages of the continuum from early years in medical school right up to the day we retire. And through individual and organizational interventions, burnout can be prevented. And from a medical legal standpoint, there is an increased risk of medical errors and poorer patient satisfaction with a burnt out physician. And burnout can lead to greater incidences of medical legal risks. So I'd like to thank Prof. Goh for his help. Remember, whenever you go through stress professionally, you are not alone. You have your friends, you have your family, you have your church friends, temple friends, don't go through it alone. Always call somebody. And I thank you for listening. Before I go, I'll lead you to this slide, which shows Dr. Tate Schoenfeld. Hang on. Okay. Sound.
U.S. working population between 2011 and 2004.
Really?
Changes in burnout and satisfaction with work-life balance in physicians and the general U.S. working population between 2011 and 2014, which appears in this issue of Mayo Clinic Proceedings. In a national study in 2011, we found that burnout was more common among U.S. physicians in the general U.S. working population. The results are concerning and suggest that 54% of U.S. physicians are now experiencing at least one symptom of burnout, up from 45% in 2011. The highest risk specialties continue to include emergency medicine, family medicine, and general internal medicine. These findings are concerning given the strong links between physician burnout and quality of care, as well as between burnout and medical errors. Studies also suggest that physicians experiencing burnout are more likely to reduce their professional work effort or cut their work hours, which could compound the projected physician workforce shortage, which is anticipated to affect the United States over the next 10 years.
Demonstrating a very strong dose-response type relationship between the experience of burnout and the likelihood that residents make major medical errors or perceive to make major medical errors in their practice. And what we've done in this study is we measure burnout, quality of life, depression, fatigue, and sleepiness at various points about every 3 months. And then we look at what is the likelihood that they make a medical error over the 3 months following that assessment.